Good morning. Thank you for that introduction, and I wanted to thank the Southern Medical Association for allowing me to present my research today. So I don't have any disclosures, but the standard Army disclaimer does apply. So the combustion of synthetic materials, including vinyls and plastics, produces cyanide. If you think about all of the synthetic materials and plastics in our homes and cars where we would be entrapped, there's a lot of them. If we think about our house at first, look at our furniture, look at the tables in front of you. It's coated in a plastic. Look at the carpet, it has synthetic fibers. Your clothes have synthetic fibers. Think about all your electronics, your TVs, your phones, your computers. All of that has a lot of plastic in it. Even down to the paint on the walls have synthetic polymers in them, all which would produce cyanide when burned. Now, if we move to our car, same thing applies. The carpets have synthetic fibers. Your seats will have synthetic fibers, whether they're cloth or leather. Your whole dashboard is plastic, as well as all of the components inside that dashboard are all made of plastic and synthetic materials. So if you're entrapped in either of these places for a prolonged period of time, you're going to breathe in a lot of hydrogen cyanide gas, which will interfere with oxygen utilization at a cytochrome level, which really contributes to early death from acute inhalation injury. Now, we don't have a great way to readily measure cyanide that comes back in a useful amount of time. Some institutions do have serum cyanide levels that they can send. At our institution, that's a send-out lab. It'll come back a week from now and won't be of any help to manage the patient in that moment. So we really have to depend on the signs and symptoms of acute cyanide toxicity, the hallmark of which is persistent acidosis despite adequate fluid resuscitation. Now, for many years, hydroxocobalamin, or cyanokit, has been the mainstay of treatment for acute cyanide toxicity. And not to have a flashback back to your medicinal chemistry class, the molecule on the bottom is hydroxocobalamin. It will bind, that cobalt atom will bind to cyanide to form cyanocobalamin, better known as vitamin B12, which will then excrete the cyanide in the urine. Recently, there have been several case reports published of hydroxocobalamin causing acute kidney injury. The proposed mechanism of this AKI is oxalate formation in the kidneys. And like I said, this has been published as case reports, and two of these case reports have been published as a letter to the editor for the Journal of Intensive Care Medicine. Now, in these patients, they were exposed, had a potential inhalation injury, and received hydroxocobalamin. Both of these patients developed renal failure and needed renal replacement therapy on hospital day 7, and both of these patients later had renal biopsies, which showed multiple oxalate crystals within multiple lumens of renal tubules. Now, like I said, this was published as a letter to the editor, so it lacks a lot of the details that one might want in further evaluating this case report. There were no details as to did either or both of these patients receive high-dose vitamin C as part of their initial fluid resuscitation. Did they receive high-dose vitamin C afterwards, potentially as part of a MERIC protocol type treatment? Did these patients have a personal history of calcium oxalate nephropathy? These are all details that were left undiscussed. So about a year later, a second letter to the editor was published in the Journal of Intensive Care Medicine, and it stated that urine oxalate levels are higher in patients who have received hydroxocobalamin. However, oxalate crystals are often seen in healthy volunteers as well as cyanide-exposed patients. This letter to the editor published an observational cohort study that included 15 patients total, 6 of which were exposed to hydroxocobalamin and 9 of which were healthy volunteers. The patients who had received hydroxocobalamin had a significantly increased odds of developing acute kidney injury as well as needing renal replacement therapy. Now again, the comparison group was healthy volunteers. These patients were not exposed to hydroxocobalamin, they were not exposed to cyanide, or any of the multiple other poisonous gases that are produced upon the combustion of these synthetic and/or natural materials. So we first sought to describe the population in which we use hydroxocobalamin. Do these patients actually have confirmed or suspected inhalation injury, or are we overusing this product? And secondly, we sought to assess outcomes in patients who receive hydroxocobalamin, specifically with the need for renal replacement therapy as well as mortality. So we conducted a PI project that was approved by our Research and Regulatory Compliance Division, which was a retrospective chart review. Now, this chart review included all patients admitted to our institution between July 1st, 2016 and April 30th of this year. All patients included had to have received at least 1 dose of hydroxocobalamin after their ICU admission. So patients who received hydroxocobalamin in the emergency department, in the pre-hospital setting by EMS, or potentially at a referring facility were not included in this analysis. So we had 35 patients that were included. About 2/3 of these patients were male with an average age of 46 years and an average burn size of 18% TBSA. Now, this is pretty typical of our patient population here. 83% of these patients did have confirmed inhalation injury via fiber optic bronchoscopy. That's not to say that the 17% that was remaining did not have inhalation injury in their smaller or distal airways that could not be confirmed via bronchoscopy. We heard in the last presentation that a fair number of the patients who have a quote-unquote negative bronch do have some degree of inhalation injury upon xenon scanning. These patients had an average admission lactate of 4.4 millimoles per liter, and as you can see, as we tried to clear this lactate, the patients had a very high volume fluid resuscitation, averaging 7.4 mLs per kilo per percent TBSA. So definitely higher than our Brook formula, our modified Brook formula, or even our Parkland formula would estimate. And 11% of these patients did receive more than one dose of hydroxocobalamin after ICU admission in an effort to clear that lactate. 63% of patients developed an AKI per the Aiken criteria during the first 72 hours of their hospital stay, with 60% of these patients needing renal replacement therapy at some point in their ICU admission. 43% of these patients did require renal replacement therapy within the first 24 hours, with the most common indications for CRRT being acidemia, volume management, and hyperkalemia. And as you see for indications for CRRT, those numbers do add up to more than 100%, indicating that most patients, or at least some patients, did have multiple indications for renal replacement therapy. In terms of lactate clearance, this took on average about 35 hours, and about a third of patients did not clear their lactate within 72 hours. And lactate clearance was defined as at least 2 consecutive lactate checks where the lactate was 2 millimoles per liter or less. Now, one patient did have a carboxyhemoglobin initially of greater than 10%. That's not to say that more patients had a high carboxyhemoglobin level. I had no way of knowing when that carboxyhemoglobin level was drawn in relation to when they got intubated, how long they were on the ventilator, were they transported from a different hospital, et cetera. The average ICU length of stay was 15 days, with an average hospital length of stay of 21 days. This is about 1 day per percent TBSA, which again is pretty typical for our patient population. And 37% of patients who received hydroxocobalamin in our study did die during their hospital stay. So in conclusion, most patients who received hydroxocobalamin developed an AKI within 72 hours of their hospital admission, with 43% of patients requiring renal replacement therapy during that initial resuscitation period. At this time, I don't think there's enough evidence to change our recommendations for the administration of hydroxocobalamin, but I do think further studies are warranted. And I wanted to leave you with an anecdote of 2 patients who were recently admitted to our burn center. This is a husband and wife, both in similar state of health, who were in a house fire about 3 weeks ago. The wife had about a 20% TBSA burn and a grade 2 inhalation injury, and the husband had about 15% TBSA burn with a grade 3 inhalation injury. Now, both of these patients received hydroxocobalamin, the wife receiving 1 dose and the husband receiving 2 doses. Now, at the time they were admitted, it was shortly after I put this presentation together, and I was kind of intrigued by these oxalate levels. So, amongst discussion with our intensivist, we decided to draw some serial urine and serum oxalate levels. So for the wife, we'll start with her. She had a grade 2 inhalation injury, got 1 dose of hydroxocobalamin. Her first 3 days of hospital admission, her serum oxalate peaked at about 9.6 micromoles per liter, with our lab value reference range being less than 1.9 micromoles per milliliter. She had augmented renal clearance per her 24-hour urines for her entire entire ICU stay, and did not develop any AKI or need for renal replacement therapy. She last week was discharged to our ward and is doing well. The husband, on the other hand, remember, he got 2 doses of hydroxocobalamin. His serum oxalate peaked at about 50, and he developed an AKI with a need for renal replacement therapy within the first 5 days of his hospital stay. He's still on CRRT, although his oxalate has cleared as of last week. And he's still in our ICU receiving that renal replacement therapy with no renal recovery kind of in sight. So again, I think we need further studies to further evaluate these relationships. Is it exposure to cyanokit? Is it exposure to cyanide or smoke in general? We don't know. So I think we need further studies to investigate this.
Good morning. I'm a general surgery resident from El Paso. However, the research I'm going to present today is performed at the Arizona Burn Center, which is where we do most of our clinical experience. Thank you so much for allowing me to speak. Today, I will be discussing the clinical significance of hyperoxia in severely burned patients. I have no relevant disclosures. So obviously, oxygen is an essential part of acute burn care. Nearly all patients initially receive supplemental oxygen in some form or fashion. For instance, severely burned patients receive oxygen after intubation, often on scene or in the trauma bay. Also, the treatment for carbon monoxide toxicity, whether suspected or confirmed, is between 4 to 8 hours of 100% oxygen, depending on the institutional protocol. So going back to what we do know, the effects of prolonged hypoxia are all too well known. What is not well known are the clinical effects of tissue exposed to supertherapeutic concentrations of oxygen for long periods of time. This is a condition known as hyperoxia. In the literature, it's generally defined as a partial pressure of oxygen, or PaO2, of 300 or greater. Within the past decade, an association between hyperoxia and mortality has been described in several subsets of critically ill patients, to include post-cardiac arrest patients, traumatic brain injury patients, and ischemic stroke patients. The correlation is slightly more inconsistent and slightly weaker in just general critically ill, mechanically ventilated patients. What has been shown is that in these studies, though, is that oxygen is given very liberally in an ICU setting, what they refer to as a permissive hyperoxia, with PaO2 targets often far above society recommendations. Unlike the end organ damage, which we know occurs with hypoxia, hyperoxia acts more like a global ischemia reperfusion syndrome. In animal models, the effects include vasoconstriction, reduced cardiac output, decreased coronary perfusion, direct organ damage from free radical formation. It appears from animal models that alveolar tissue appears to be particularly susceptible. The effects of hyperoxia have not yet been investigated in burn patients. Here we attempted to quantify the average amount of oxygen given during initial burn resuscitation, the incidence of carbon monoxide toxicity, and if hyperoxia was associated with increased hospital mortality or ventilator-associated pneumonia. We conducted a retrospective analysis of burn patients admitted to the Arizona Burn Center with greater than 20% TBSA burns from 2015 to 2018. The focus of this study was oxygenation within 24 hours of admission. The outcomes were in-hospital mortality, as well as the complication of ventilator-associated pneumonia. We defined inhalational injury as mechanism, carbonaceous sputum on bronchoscopy, extensive facial burns that sit within the mouth. The diagnosis of ventilator-associated pneumonia we defined as positive cultures or radiographic evidence treated with antibiotics. Carbon monoxide was defined as serum carboxyhemoglobin greater than 10%. We collected the first PaO2 available upon arrival to the emergency department, the worst PaO2 for each patient, along with the corresponding fraction of inspired oxygen, or the FiO2. So here depicted graphically, we defined the worst PaO2 as the lowest PaO2 when FiO2 was less than 0.5, and the highest PaO2 when the FiO2 was greater than or equal to 0.5. This definition had been previously published by Eastwood and colleagues in 2012, looking at critically ill, mechanically ventilated patients in an ICU setting. Because there is no consensus in regards to which PaO2 is clinically relevant, we compared the first and the worst PaO2 to see if they were statistically different. The relationship between oxygen parameters and outcomes were assessed using linear regression models, adjusting for injury severity using known independent predictors of mortality. Overall, 252 patients were identified with burns greater than 20% TBSA during our time interval. However, 33 were excluded if they were transferred from another facility, if they were discharged to hospice, or they did not have an ABG available within 24 hours of arrival. A total of 219 patients were included in our analysis. Here you see the baseline characteristics of our cohort. As you can see, the majority of our patients were middle-aged Caucasian males with extensive burn injuries. Our average TBSA was 45%. Nearly 10% were diagnosed with carbon monoxide toxicity on serology, and 48% presented with clinical evidence of inhalational injury. The average first PaO2 available in the emergency department was 332, which correlated to an average FiO2 exposure of 90%. Within the 24 hours of initial resuscitation, about 60% of these patients were at some point hyperoxic, greater than 300, and the majority of patients, about 80%, were at some point on 100% FiO2. A total of 91, so 41.6% of patients developed ventilator-associated pneumonia in our cohort, and the average mortality in our cohort was 37%. The first PaO2 and the worst PaO2, as defined earlier, were not statistically significant with a p-value of 0.2. We found that the worst PaO2 was associated with an increased mortality with a small odds ratio after adjusting for TBSA and inhalational injury. Similarly, carbon monoxide toxicity was associated with increased mortality. Neither PaO2 nor carbon monoxide toxicity was associated with the diagnosis of ventilator-associated pneumonia. We found that early exposure to hyperoxia in severely burned patients is very common and associated with an increased overall mortality after adjusting for injury severity. Aside from this, there are several findings I'd like to discuss. First, the average amount of oxygen delivered during initial burn resuscitation was higher in our study than previously observed in mechanically ventilated patients in an ICU setting, which ranged between 50 to 62%. One possibility is that our cohort consisted of more severely injured patients. Another reason, which is more likely, is that oxygen was more liberally administered to burn patients compared to other subsets of critically ill patients. This makes sense considering the usual pattern of burn-related injuries. In our data, inhalational injury was common in high surface area burns, and these patients are often intubated quickly for airway protection. Once intubated on scene, we found that they were already hyperoxic on arrival, indicating that they were transported on high levels of FiO2. General ICU guidelines recommend that when you place patients on mechanically ventilated patients, they start at 100% FiO2 until you're able to rule out baseline hypoxia, and then you titrate down as tolerated by the patient. However, burn patients generally fall out of these recommendations due to the possibility of carbon monoxide toxicity, since PaO2 and SpO2 are not reliable markers in that setting. The rationale for giving oxygen is that it competes with carbon monoxide for hemoglobin molecules. 4 to 6 hours of 100% oxygen will displace approximately 90% of carbon monoxide toxicity, or carbon monoxide in the blood. The protocol at the Arizona Burn Center is to give 8 hours of oxygen. With severely burned patients, the subtle clinical exam findings of carbon monoxide toxicity are lost, and we know that carboxyhemoglobin labs are often inconsistent since they're dependent on baseline pulmonary functions and when the lab was drawn and how much time elapsed from the initial insult. So there's a much lower threshold to empirically place these patients on several hours of 100% oxygen based on mechanism alone. What is interesting is that we found no association between FiO2, PaO2, and the presence of carbon monoxide toxicity. This seems to mean that high concentrations of oxygen were not preferentially just given to patients with confirmed toxicity. And if we assume that oxygen was given empirically based on mechanism, this suggests a poor correlation between suspected and confirmed toxicity. Studies already show the diagnostic value of pre-hospital point-of-care testing with carbon monoxide oximetry. It would be interesting to see if routine use of these point-of-care testings or point-of-care testing would somehow reduce the amount of oxygen delivered prior to arrival. Our study was retrospective and obviously limited to the experience of a single institution. However, it was adequately powered. This study is exploratory. As such, it asks several questions and answers fewer questions. Studying hyperoxia, there is no consensus in the literature in regards to which marker of oxygen concentration is clinically relevant. Previous studies have investigated the first PaO2 available, the worst, the average PaO2, and a time-weighted PaO2. We do not yet understand if exposure is dependent on a single exposure or a single incident, or if it's time spent above a certain threshold. However, our data shows that several of these metrics, to include the first and the worst, are not statistically different and would all possibly reach similar conclusions. In conclusion, after adjusting for injury severity, there was a positive, statistically significant association between higher oxygen levels and mortality. We are unable to say at this time, as in the rest of the literature on this subject, if this is a marker of injury severity or if this represents a causal relationship. What we did see is a higher delivery of oxygen was observed in acute burn care resuscitation compared to other subsets of critically ill patients, likely from pre-hospital treatment, as well as suspected carbon monoxide poisoning. However, interestingly, there was no association between more oxygen given and higher levels of carbon monoxide in the blood, perhaps indicating an indiscriminate use of oxygen in resuscitation. These are questions to address in future studies.
Our team has nothing to disclose. Grady Health System is a large academic medical center in the heart of Atlanta. We are a safety net hospital with a level 1 trauma center and a large verified ABA verified burn center for adults and peds. We're a 22-bed unit with over 700 admissions a year. Pain management, as we all know, is a cornerstone in burn care. And we are all aware that poor pain control can lead to lots of complications. So that includes improper wound care leading to potential infection. Inappropriate pain management in the acute setting can actually lead to chronic pain issues as well. And as practitioners, we're all aware of these issues. We're also aware of the fact that pain management in the burn injury as well as the burn healing process can be multifaceted. We're dealing with nociceptive pain. Patients are also a lot of times dealing with lots of inflammation. We have to manage procedural pain. We have to manage pain around PTOT. And that presents with a lot of things to address from a multifaceted perspective. Outside of the burn literature, there is a lot of data now suggesting that initial opioid exposure during an acute injury can be a gateway for increased opioid use and dependence. Unfortunately, we do not have burn-specific data to tell us otherwise. So as responsible providers, we have to at least take this data and not dismiss it, take it with a grain of salt. Opioids, of course, have remained the mainstay of pain management in burn injuries. However, with the opioid crisis around us, we're finding that there is some provider reluctance in prescribing opioids. We're also finding when we're able to prescribe opioids that community pharmacies are refusing to fill. And we're also having to deal with insurers that are setting caps on how much opioids they will fill for a patient within a certain time frame. With that in mind, we sought to retrospectively evaluate our pain management practices using both opioids and non-opioids in adult patients that were admitted to our burn center with small burns. These small burns we defined as any burn less than 20% TBSA. And this was an IRB study that looked at patients 18 years and older between January of 2014 and April of 2018. And we randomly picked 100 patients as our sample size. We used descriptive statistics to describe our data. The point of the study was to look at the care continuum. So we had snapshots during inpatient pain management, the pain management plan on discharge, as well as the first clinic visit. The primary outcome was to look at the percent of patients with burn injuries that were discharged with an opioid prescription, see how many of those were there. And then we also looked at IV opioid use during the inpatient stay. We looked at the morphine milliequivalent use that was ordered on discharge. We compared the final day prior to discharge in terms of opioid use with what the patient actually left with as a prescription. We also looked to see what we were doing in the realm of non-opioid pain management. And we compared a lot of this information as well at the first burn clinic visit. And ultimately, we were also interested in looking at the percent of patients who were readmitted within 30 days for uncontrolled pain. Our patient population consisted of 60% males, median age of 40, median weight of 76, so they weren't too big. The half of the population was Black patients with 30% whites. We also collected data on substance abuse as well as chronic pain and psych history. As y'all see, the numbers look pretty low. I think this is grossly underreported. A lot of times we find out information that does not make it into the chart, unfortunately, that does complicate pain management. Most of these patients were thermal injuries with a median TBSA of 5%, so they weren't necessarily large burns. However, most of them were deep partial thickness or full thickness, requiring 60% of patients to actually undergo surgical intervention. And most of these patients, we didn't report out whether these were autografts versus porcine placement, but most of these patients would have received an autograft and not just porcine for pain management. And the median length of stay of these patients was anywhere between 2 and 9 days with an average of 5 days. We found that 95% of our patients did end up leaving with an opioid prescription. And this is the breakdown of the opioids that they received. So the 70% in blue is the combination oxycodone, Tylenol, i.e. Percocet, followed by 15% in red of plain oxycodone. It is extremely important to realize that these are patients who are receiving just immediate release opioids, and we'll talk about that later. And then we had only 5% of patients did not receive any opioids whatsoever. During the patient's hospital stay, they received IV opioids about 50% of their time in the hospital, and the mean daily morphine milliequivalent dose prior to discharge was around 30 milligrams. That's equivalent to 20 milligrams of oxycodone daily, which is basically your 5Q6 PRN. On discharge, though, we found that patients were leaving with a median total morphine milliequivalent of 60 milligrams, so that's double of what they had used the day before. The median day supply on discharge was 6 days, which is consistent with when we would first see them in clinic. Typically, we see them within the first week in clinic. And we also looked to see how many patients actually ended up receiving more than what they had received the day before, and that was at 76% of patients, which is alarming. In terms of co-prescription, 84% of patients received acetaminophen as well because of the combination acetaminophen and oxycodone. Only 23% received NSAIDs. Only 1% received benzos, and none of these patients left with gabapentin. At first clinic visit, we looked at the median pain score, which has a lot of limitations. This is the patient's self-reported pain score, but it was only 3. 50% of patients required a new opioid prescription during that first visit around day 7. And this prescription, 70% of them had no changes in doses, while 5% had a dose increase. And in 25% of cases, patients actually had a dose decrease. We only had 6% readmission rate for patients, with 2 patients out of that 6%, only 2 were readmitted because of pain and poor wound care. So in conclusion, most of our patients received a pain regimen that included an opioid, mainly an immediate release opioid. The reason this is important is because there is data suggesting that writing for long-acting opioids has a higher risk of exposing this patient to prolonged opioid use down the line. As we saw, acetaminophen was typically frequently used. However, NSAIDs were only used in a quarter of the patient population, and on discharge, 75% of patients were receiving more opioids than what they needed the day before. However, we did have a low rate of benzodiazepine co-prescribing, which again is extremely important because data outside of the burn world is suggesting that co-prescribing of benzos along with opioids can increase risk of overdose. On first clinic visit, 50% of patients still required an opioid prescription at the first clinic visit. So where are some opportunities? One of the things we realize, of course, is that we probably have room to work on optimizing non-opioid medications, and that can either be protocol-driven or order set-driven. So when should we be utilizing NSAIDs? Are they appropriate for everyone? Is there a threshold? Are there patients who are higher risk? We've worked quite a bit in including NSAIDs now more, but every now and then you get the patient who surprises you, the perfect patient who would have been perfect for NSAIDs, and they bleed on you nonstop. So we recently had a case of that, and we've been very aware, trying to evaluate whether NSAIDs are truly for everyone, yes or no. When you put something like this in an order set, a lot of times things get ordered regardless. We had a patient recently, an 85-year-old, who was on scheduled NSAIDs. So where do you draw the line? How do you define these right patients? The other thing to potentially consider is the role for topicals. Is there a role for adding lidocaine patches close to the donor site? Is there any role for gabapentin for acute pain, especially for small burns? Another thing that we're learning, we are an academic medical center. We have residents that come through every month, and they change. So as the patients transition from pre-surgery care to immediately post-op to when they're ready to discharge, are we cleaning up the medication list appropriately? Are we discontinuing unused meds? Are we consolidating opioids? Or does your MAR include a PRN tramadol, a PRN oxycodone 5, and a PRN oxycodone 10? And then whoever is reconciling the meds on discharge is choosing whatever they want to send the patient on. Again, close evaluation of the patient's opioid needs prior to discharge is extremely, extremely important. As you saw, this was eye-opening for us because we didn't realize that we were sending patients on more than what they actually had used the day before. And thankfully, with our recent EMR upgrade, we utilize Epic, and Epic is actually able to incorporate an inpatient morphine milligram equivalent dose calculator, which I have screenshots of that up there. There are a few things that we can see from that view. I can see everything that's ordered for the patient. So I see an oxycodone 5 or an oxycodone 10. Right, it shows you the different days that for the view. So 12/3, yesterday, today. It will tell you how much the patient can get total from that dose, and it will calculate it for you. At the very bottom, this patient was also receiving morphine IV 2 milligrams, and it will tell you exactly how much the patient is getting. So I can see that where it says yesterday, for example, in that column, down here, I can see that the patient didn't get any of his oxycodone 5. I can see that the patient got 45 morphine milligram equivalents of the oxycodone 10, which is 30 milligrams of oxycodone that day, but the patient is still IV morphine dependent. And from there, I can start making my assessment regarding how we're going to come off the IV morphine and what appropriate oxycodone dose the patient should be leaving with. So this just rolled out a couple of weeks ago. I'm hoping that this will actually really help us drive a lot of that reconciliation on discharge to appropriately send the patients with what they need only and not extra. Additionally, as I mentioned, as an academic medical center, it is extremely prudent that we get our residents on board. We've been working on incorporating a medication, if you will, a medication-driven orientation at the beginning of rotation, and that includes both what your order sets entail, what are things to look out for, and pain management has been one of the things that we talk about. Additionally, as we all know, it's extremely important to get both patient and family on board from day one, and that requires a ton of nurse education for the family, that from day one, unfortunately, your pain is never going to be a 0. We're working towards a tolerable pain score. And on discharge, we really should also be addressing opioid side effects, opioid risks, as well as opioid disposals. There is literature suggesting that surgical patients, 70% of surgical patients sometimes leave with opioids that are never used. And these opioids are sitting around at home. They can be a danger to kids, they can be a danger to pets, they can be a danger for diversion. And a lot of times we're not talking about that. And ultimately, we need to discuss the continuity of care in clinic. At 50% opioid re-prescribing in clinic, again, there is data suggesting outside of the burn world that if you write for opioids the second time, or if opioids during an acute event are continued beyond 7 days, that the patient actually has double the risk of being on an opioid a year later, which is quite alarming. Fortunately, we have a close team where we are always communicating. Our providers are the same who are providing care inpatient and outpatient, and we have very close communication with our APPs who see our patients in clinic. Some of our future directions, of course, would be including anxiety, itching, and sleep in the equation. Looking at our different wound management strategies that can assist, so that includes your silver-impregnated dressings, that includes are using liposomal bupivacaine for your donor site pain, or are you spraying donor sites with RECELL. At this very meeting, people have reported positive outcomes with that. And then again, looking at clinic visits post that first clinic visit. When is the patient coming off the opioids, and how are they doing physiologically? And then ultimately, do we have the same risk? This question always comes up as a discussion for us, because can we truly use the data that's out there and say that our patients are going to get addicted to opioids? Because that's what every other patient population has said. Again, I don't think this is data to be dismissed, but we don't know for sure that this would actually apply to our patient population. And with that, I would be happy to take questions.
Thank you very much, Dr. Dayag.
I am Ryan Howard, and I'm here on behalf of Dr. Garcia to present the inter-hospital variation of inpatient versus outpatient pediatric burn treatment after the emergency department evaluation. I'm the pediatric burn program manager in the Children's Hospital in Charleston, South Carolina, and I'm a master's prepared nurse. We have no disclosures to present. Pediatric burns make up a significant portion of burns in the United States. In fact, children account for nearly 25% of all burns. Additionally, children under the age of 6 years old make up a disproportionate share of these burns, most of which are scalds or non-severe burns. In fact, it's been estimated that about 90% of the burns can be managed with outpatient care. Management of pediatric burns in the outpatient setting is successful when healthcare is easily accessible for wound care follow-up, adequate pain control during debridement and at home, when patients have minimal comorbidities, along with adequate home support. Developments in telemedicine have allowed patients to be followed by burn specialists with more ease. And just recently at our institution, our pediatric burn team worked with developers to create a smartphone burn app that aids in the outpatient management of non-severe burns without requiring a face-to-face visit. Despite these developments, some institutions have reported high admissions or transfer rates for non-severe burns. Variability in care of burns has been reported and criticized, with overutilization of patient transfer to burn facilities and even high admission rates. For this study purpose, small non-severe burns will be defined as less than 10% total body surface area. Contributing factors can lead from the burn centers and their availability. This slide shows that there is about a 30% decrease in verified burn center. About 25% of the United States population lives within about an hour of a verified burn center, and about 40% of the United States population lives within an hour of a self-described burn center. The loss of access to burn center results in a loss of medicine and emergency medical exposure to burn care. It can lead to inadequate coordination of specialized burn care within the emergency department. There can be a perceived need to admit in less experienced centers, and inexperience can lead to higher numbers of admissions. Treating non-severe burns in patients can expose patients to unnecessary infectious risks. Due to the nature of the study, we were able to see that the distribution of patients' socioeconomic status or their insurance status, but this could be playing a part. Therefore, we hypothesized that we would find variation in practice among pediatric burn referral centers between inpatient and outpatient management decisions of these small non-severe burns. Remember, those are less than 10%. The database used was the Pediatric Health Information System, known as FIS, and a national administrative database with de-identified information. FIS focuses on resource data for inpatient and ambulatory surgery, as well as ED observation encounters, including a large billing data set that relies on accurate healthcare coding. This database was used in order to capture the outpatient pediatric burn population standardized decision for management of outpatient versus inpatient. We did a query over 2017 fiscal year identifying non-severe burns, again, those that are less than 10%, comparing inpatient observation and outpatient. Our search yielded 34 hospitals that met inclusion criteria. This included almost 4,000 burns, with a range of 83 admissions per institution. There were 624 admissions, 429 observation admissions, and 2,700 outpatient or emergency department only encounters. While 72% of outpatient management of the non-severe burns is not too far off from the early estimated 90%, if you look at the ranges on the right, you will see there's a pretty wide variability in the numbers. 24 of the institutions had both inpatient and outpatient, and 11 had data on one or the other. We wanted to graphically show this distribution, so this graph here has the de-identified institutions across the x-axis on the bottom. In blue are the outpatient managed encounters, which you can see the institutions on the right of the graph treated non-severe burns exclusively as outpatients. However, as we move to the left side, yellow, which is observation, and red, which is inpatient management. Until you fill in, you will reach one institution, which was 100% inpatient management. And again, all of these hospitals treated greater than 15 burns. The lowest number of burns treated, in fact, was 23, and this institution in red was at about 50. Looking at this data slightly differently in the form of a histogram, we saw a bimodal trend of high hospital utilizers over here on the left. The percentage outpatient is across the bottom, and these hospitals manage non-severe burns as 0 to 30% on the outpatient basis. These institutions, on average, managed only 8% of their non-severe burns as outpatients compared to the low hospitalized utilizers who managed 80% of the non-severe burns as outpatients. Next, we analyzed patient charges associated with each type of management. It probably doesn't come to much as a surprise that the inpatient and observation had higher charges compared to outpatient management. However, the magnitude of the difference is very impressive. The median charge for outpatient was $1,420 compared to the inpatient at over $47,000. The outpatient charges ranged from $471 through $2,500 compared to $9,000 through $5.5 million for inpatient. Observation charges were also significantly high compared to outpatient with a median charge of over $10,000 and a range from $5,600 up to $1.7 million. Both inpatient and outpatient observation charges were compared to outpatient were statistically significant. Observation charges were significantly lower compared to the inpatient as well. Trends in management. So to summarize the trends that we're seeing here, we saw that the decisions regarding the treatment varied regarding on inpatient versus observation versus outpatient management. Distribution of the institutional management can be categorized in a low and high hospital utilization. Observation management charges were 7 times higher than the outpatient, and most impressively, compared to the outpatient charges, inpatient management was 33 times higher. There were definitely limitations to our study, and here we will acknowledge them. There are certainly risks inherited when you're using an administrative database for outcome assessment. For example, was the coding accurate? Were the patients lost in follow-up? And this is a limited patient population. Our healthcare system is constantly changing and evolving, and so is the reimbursement system. Although this is constantly changing and we really can't be sure what the future holds and what direction it will be moving, but as it stands, there will be a focus on improved access to primary care, making outpatient burn more viable as more people are incentivized to obtain insurance. There are always ways that we can smoothly trend toward more outpatient care for these small, non-severe pediatric burn patients, remembering those that are less than 10%. Providing continuing education to medical staff and incorporating more telemedicine, allowing reimbursement to be the same for telemedicine as an actual face-to-face visit. In conclusion, there's a wide variability in admission practices for small non-severe burns, again, those that are less than 10% in the pediatric burn population. The United States healthcare system is moving towards accountable care organizations with population-based reimbursement modules and a focus on bundling of care. A need for focused cost-saving measures in healthcare is becoming more apparent, and based on our study for small non-severe pediatric burn patients is an area that can greatly improve cost efficiency in high-volume burn centers. Thank you to our pediatric burn team and Dr. Garcia again for letting me present this data, and to the committee for allowing me to present. And are there any questions?
Hi, everyone. Thank you for letting us present our work today. I'm Philip Campone. I'm one of the research residents at the ISR. I'll be talking about fractionated CO2 laser therapy and the treatment of hypertrophic burn scars. There we go. A standard disclaimer, we have no disclosures. Hypertrophic scarring remains a major source of morbidity for patients who suffer burn injuries. These scars develop as a result of a profoundly dysregulated inflammatory response to the injury. This response is characterized by excess levels of inflammatory cytokines in and around the wound, and ultimately excess collagen deposition in the wound bed that causes the scar. There are a number of treatment options for these, ranging from medical options to surgical interventions. Medical treatments typically have have highly variable rates of efficacy. Surgeries in a select group of patients can produce pretty reliable benefit, but these are typically accompanied by their own morbidity profile, as this represents a more invasive intervention. Fractionated CO2 laser therapy is a treatment modality that has been utilized for the resurfacing of other types of scars and more recently has been employed in the treatment of burn scars. This therapy works by vaporizing water in the most superficial layers of the skin, and in doing this, it ablates those layers of tissue. In addition, the laser therapy actually works at a cellular level by reducing the levels of pro-collagen mRNA transcription, as well as levels of TGF-beta that are present in and around the wound. And again, both of those two things are critical in the hypertrophic burn scar development in the first place. So there's been a pretty decent amount of literature at this point published looking at subjective improvements in scar characteristics after CO2 laser treatment. There's been much less literature published looking at objective measures of treatment response. And so what we wanted to do as part of a process improvement project was to pick one such objective measure, in our case scar thickness, and then pick a modality that anybody across the country really can replicate, which is an ultrasound. These are available in basically any clinic anywhere. And so we aimed to evaluate the effect of fractionated CO2 laser therapy on hypertrophic burn scar thickness using ultrasound as a point of care test. So we followed, as part of this PI study, patients who were normally undergoing their CO2 laser therapy. We selected a single site and followed this with serial ultrasound measurements over the course of treatment. Additionally, we wanted to look at whether certain patients benefited more from this therapy than others would. And so to do that, we broke our patients into two groups. The first group are patients with thicker scars at baseline, so those with a initial scar thickness greater than the median value. And then group two were patients with thinner scars at baseline, so patients with an initial scar thickness less than the median value. This is the laser that we used, as well as the settings, and then at the bottom is the ultrasound and probe. These are representative images taken from our ultrasound. On the left side of the screen is normal skin. On the right side is hypertrophic scar. And this projects just about as well as we can see it in the clinic. The red arrows denote where the observer would have placed the calipers to produce the measurements. We compared our groups using Kruskowski's testing and then corrected for our post-hoc testing, which I'll describe in a minute, using a Bonferroni correction for multiple tests. In total, we followed 21 patients, the majority of whom were male. The most frequently injured site was the extremity. The initial scar thickness median was 0.71 centimeters. All of our patients completed one laser treatment. Just under half completed two, and then just over a quarter completed 3 treatments. This is a figure looking at scar thickness, which is represented on the y-axis, measured in centimeters, and then time is on the x-axis and is measured by treatment. So overall, there's a significant reduction in scar thickness over the course of therapy, with increasing reductions with further and further treatments. So for our post-hoc analysis, we went back and compared the median and range seen at each of the subsequent visits back to the original baseline value. And on those individual tests, we found that the statistical significance appeared after 2 visits. So it took 2 visits for these patients to show a significant improvement in their scar thickness. This is a table looking at our subgroup analysis. On screen left are the thicker scars, so greater than median value at baseline. On screen right are the thinner scars. You can see here that there is a significant reduction, again, in scar thickness among the thicker scars group. And interestingly, this difference is actually present after just 1 treatment session, so a little bit quicker than the overall population as a whole. Among the thinner scars, these scars actually did show improvement as well, but this trend did not reach significance. This figure compares our 2 groups to each other. So group 1 here are the thicker scars, and they're represented by the white bars. Group 2 are the thinner scars, represented by the filled-in bars. At baseline, there's a statistically significant difference, as there should be, because we created these groups to be 2 distinct populations. But this difference is actually lost after just 1 treatment. So after 1 round of the CO2 laser, the thicker scars actually began to resemble the thinner scars, so substantial benefit in that population. Our study has a few important limitations that should certainly be discussed and taken into account, probably the most important of which is a lack of controls. We did not measure either normal skin or untreated burn scar, and both of those would have been useful in calculating what % of our change could be attributed to natural scar remodeling. Additionally, scar thickness is only a single measure of a complicated scar, and so patients may have actually received substantial benefit from this treatment modality, but if they did not show an improvement in their scar thickness, this might have been lost in our analysis. And then finally, because this was a PI project, patients could return to clinic for as many visits or as few visits as they wanted, and so a variable number of treatments were completed. And as such, our data is much more skewed towards the earlier observations as opposed to the later observations. For the last visit, visit 3, that accounted for only 6 patients out of our initial population. In conclusion, patients with hypertrophic burn scars who are undergoing fractionated CO2 laser therapy, there appears to be more benefit among patients with thicker scars relative to thinner scars. Ultrasound, a point-of-care technique, is readily available to measure this difference as patients progress through treatment. And our final conclusion must be taken with the caveat of the limitations already discussed, but we can say that fractionated CO2 laser therapy does appear to improve hypertrophic burn scar thickness overall. Our research raises a few interesting questions that further research should likely investigate. First of all, given that this therapy appears to modulate elements that are involved in that dysregulated process causing hypertrophic scar formation, might it be useful to push this modality into earlier treatment times closer to the point of injury? Secondly, no one has really optimized the laser settings for use with this particular indication, and there are a few different schools of thought out there as to which will work best, and so some research should probably be devoted to maximizing what we can get out of this technique. And then finally, are there other objective measures of treatment that can be looked at in a clinic setting, in a non-academic center, that everyone really can reproduce across the country? I'd like to acknowledge the ISR and the clinicians listed here, and then I will take any questions. Thank you.
I have no disclosures related to this presentation. Here are the contributors to this research, their respective disclosures. None of their disclosures directly relate to this presentation. Here are the objectives that we're going to cover today. Sepsis continues to be a leading cause of mortality and morbidity worldwide. In the United States, it's estimated that half the hospital deaths are somehow sepsis-related. Sepsis is also costly not only in the human terms, but is costly in financial terms as well. A recent study estimates that if a patient develops sepsis as an inpatient, it adds approximately $51,000 to their hospitalization cost. It is also recently estimated that the cost of sepsis treatment and care in this country approaches $24 billion a year annually. To put this in perspective, if you took 24 billion $1 bills, put them in a stack, that stack of bills would be 6 times higher than the orbit of the International Space Station. Rapidly recognizing and treating sepsis in non-burn injured patients is challenging, and studies have shown that delays in treatment for these patients could negatively affect outcomes. It's even more challenging in burn patients, the reason being the hypermetabolism and the decreased immune function related to their burn injury. If a burn patient survives the first 24 hours after their injury, the leading cause of death becomes multi-organ dysfunction syndrome. And 83% of the time, it is preceded by some sort of an infection. If a burn patient develops sepsis, it's estimated that the mortality rate for our burn patients that develop sepsis published is between 28 and 65%. Vitamin C is an important part of our dietary intake. As a side note, while preparing for this presentation, it does appear that scurvy seems to be making a comeback around the world. So along with pirates, vitamin C supplementation has been shown to improve some things for burn-injured patients and people with sepsis. Burn-injured patients, published research has indicated that it can decrease initial fluid resuscitation volumes, it can decrease edema formation, and it may also, we do know that it does improve wound healing. In our burn center, our standard practice is to administer vitamin C supplementation to our burn-injured patients with TBSAs of 20% or greater. Our standard supplementation, vitamin C, is 1,000 milligrams of ascorbic acid by mouth twice a day. Unless you've been in a cave for the last 2 or 3 years, you have, actually I want to back up. In sepsis patients, sepsis has not had a lot of studies that have been done in humans. Most of our studies are in animal models and in vitro studies. In these models, sepsis has been shown to improve the microcirculation and perfusion, decrease cytokine release, and there's some indication that it may actually have a bacteriostatic property to it. In human studies, the limited ones that are out there show that vitamin C supplementation in sepsis may decrease SOFA scores, decrease the inflammatory markers that we see, and they have seen that septic patients do tend to have a decrease in their initial vitamin C levels. This is the study that made all the news about 2 years ago, so unless you've been in a cave, you probably are familiar with this study. I'm not here to debate the merits, strengths, or weaknesses of it. Discussion of this study in medical circles can reach the fervor of discussion of politics and religion. But the one thing of this study, it looked at 94 patients, non-burn injured, in a non-burn ICU that was in general ICU. The 94 patients, they were able to get vitamin C levels of these septic patients in 22 of the septic patients. The vitamin C levels in all 22 of these septic patients were gotten prior to any intervention, and all 22 of these vitamin C levels were below the normal limits. With this in mind, we had never really tracked this, so we decided to add vitamin C levels to our burn sepsis algorithm. And this is a brief overview of how that works. A burn sepsis algorithm is a staged process. The first one uses patient vital signs. This is done at least twice a day, can be done other times as needed. We do have built-in snooze periods where the screening does not take place, but based on clinical condition of the patient and provider clinical judgment, we can screen during these snooze periods. So the way this works is, if you do not meet the criteria in Section A, or you don't meet 2 of the 3 criteria in Section B, then no further screening or workup is done. If you meet either of the criteria in Section A or 2 of the 3 criteria in Section B, then the initial sepsis criteria is met, and then we obtain some additional lab work as part of this process. The labs that we obtain are CBC, BMP, lactate, and procalcitonin. And this is where we started the process of obtaining initial vitamin C levels. As these labs come back, they're evaluated against the screening tool that you see here. If at least one of the criteria in C and one of the criteria in D and E are not met, no further screening is done, and then we go from there, and they can be rescreened later as appropriate. If you do meet one of the criteria in Section C and one in D and E, the code sepsis criteria is met. At that point in time, we obtain cultures, get x-rays, chest x-rays of our non-intubated patients, and antibiotics are administered. For the purposes of this research study, we determined or deemed the patient was considered to have an infection if at least one of these 3 things happened. A bronchoalveolar lavage returned greater than 10 to the 5th colony forming units. Imaging was read as either an infection or consistent with an infectious process, or the blood cultures came back as positive. We did a retrospective chart review of all adult inpatient admissions from July 1st, 2018 to March 31st, 2019. We had 207 adult admissions during this time period. We had 59 sepsis screens that we were able to use the previous criteria to make a determination if they were infectious or not. And out of that 59 patients, we had 37 vitamin C levels that were associated with those screens. Here are our results that we found. When it comes to age and TBSA, between the 2 groups of infected and non-infected, there was really no significant difference by it. The initial vitamin C level is actually kind of interesting. It's slightly higher than the non-infected group, but it was not statistically significant, and we'll explore this here a little bit further momentarily. We looked at the prognostic ability of the initial vitamin C level as a test for diagnosing sepsis using area under the curve for a receiver operating characteristic curve. For those not familiar with this type of analysis, reading of 0.5 means the test is worthless. A reading of 1.0 means that it's a perfectly done test, a perfect diagnostic test. Our results was 0.67, so that means that just the initial vitamin C level in and of itself for diagnosing sepsis is not a very good prognostic test for that. This is a box and whisker of all 37 of our patients. Our infected group had 24 patients out of the 37. The non-infected group has 13 of the 37. We've broken it down between the two groups. A couple of things stand out. One, in our infected group, only one patient had a level, a vitamin C level, initial vitamin C level of less than normal. And all the patients in the infected population were receiving vitamin C supplementation during their admission and at the time of their sepsis screen. Non-infected population, there was only 2 patients that was not on vitamin C supplementation, and that's 2 of the 3 patients that you see here below normal in the non-infected group. Their TBSA was less than 20%, and as per our standard practice, they would not be receiving vitamin C supplementation as a normal course of the treatment. But the remainder of those patients in the non-infected group were receiving vitamin C supplementation. You can see visually at least that the infected group does appear to be higher initial vitamin C levels in the non-infected group, but as mentioned earlier, the difference is statistically non-significant. One thing I'd like to draw your attention to are the 3 data points that are 3.5 or higher. 2 of these 3 patients that are highlighted in red actually died during their admission. And we have no explanation for why that occurred and why the levels were so high. We recognize there are limitations with our study. It's a single center retrospective chart review with limited data points, but some things did stand out from our analysis of the data. One thing is that initial vitamin C levels in and of themselves are not a good prognostic test for sepsis. We kind of figured that out. Only one of our 24 septic patients or infected patients had vitamin C levels initially below normal limits. This is in stark contrast to Merrick and his population, where all 22 of his infected patients and his group's infected patients had vitamin C levels that were below normal. The other thing that kind of stood out is for those that had extremely elevated vitamin C levels, 2 of those 3 patients have died during their admission. We answered the question, does the initial vitamin C level matter from our research? Maybe, maybe not. We just don't know. It didn't really provide us any definitive answers. One thing that we did kind of figure out with this is we've got a bigger question. Given our limited size and the limitations of the research, are we starting to pick up some sort of signal out of the noise related to vitamin C in sepsis and burn-injured patients? We don't know. Maybe we hear a signal, maybe we hear static or noise. If we do hear a signal or are picking up a signal, what's driving that? Is it something specifically related to burn-injured patients? Is it something related to our supplementation with vitamin C, or is it something entirely different? We believe that given some of the outstanding questions and the new questions that kind of popped up in our research, that further research on this topic is warranted. Thank you.
So we'll open the floor to any.
I was wondering if you would say Belinda Gomez is in the program. Unfortunately, she wasn't able to make it today. My name is David Burmeister. I'll be presenting in her absence. Thank you for that introduction. Here's our standard Army DoD disclaimer. Other than that, I have no relevant conflicts of interest to disclose, other than potentially the fact that I am a translational physiologist and not a clinical practitioner per se, so I'll be looking at things through the eyes of a basic scientist, if you will. Are associated with a systemic inflammation mediated in large part by a cytokine storm, among other things that, if left untapped, can lead to profound immunosuppression that can put the patient at risk for sepsis and other infectious complications, ultimately into organ dysfunction. And sepsis in of itself is one of the leading causes of death among the initial survivors of the initial resuscitation phase. It's a lethal occurrence in the burn ICU, and diagnosis of sepsis in the burn patient is exceptionally difficult. There's different definitions or diagnostic criteria that have been looked at, all with inadequate sensitivity and specificity. And specifically in the diagnosis of sepsis is difficult in the burns because a burn patient will present with septic criteria in the absence of sepsis, and then sepsis can occur in that burn patient in the absence of a definitive positive blood culture. So if we think about this last fact and consider the endosymbiotic theory, wherein mitochondria have evolved from a bacteria and they have similar structural components, et cetera, as you can see on the right, it's interesting to think about the effect of mitochondrial DNA in terms of paracrine host damage. And indeed, it's been shown that mitochondrial DNA has acted as a DAMP, a danger-associated molecular pattern, which is analogous to the bacterial pathogen-associated molecular patterns. And DAMPs and PAMPs, again, have very similar actions within the host. This isn't necessarily a new phenomenon. This has been shown in other trauma patients as well as in other ICU patients, and it's, to our knowledge, hasn't been looked at in the context of burn injury, wherein you can imagine the massive tissue destruction would lead to a lot of cellular debris release, including mitochondria. In these patients, papers shown here, that the source of the mitochondrial DNA has been proposed by some to be peripheral blood mononuclear cells, or PBMCs. And what's also interesting is that PBMCs have been shown to contain less mitochondrial DNA in septic patients, and in certain populations of septic patients, their mitochondrial function, or oxidative phosphorylation, has shown to be altered in that absolute levels are reduced, as well as a increased leak respiration, which I'll get to here shortly. And to our knowledge, like I said, this has not been looked at in burn injury. We have a recent paper accepted. This is in a preclinical porcine model of 40% TBSA burns that shows that although absolute numbers of lymphocytes are reduced, which has been known for some time, their oxidative phosphorylative capacity is actually increased, but not in sufficient amount to atone for the decrease in lymphocyte numbers. But long story short, our overall objective in this study was to turn the screen off. There we go. Was to look to see if PBMC oxidative capacity or circulating mitochondrial DNA levels could potentially prove as diagnostic biomarkers in sepsis and burn patients. And we did this in a prospective observational fashion. Adults admitted to our burn center with over 15% TBSA were divided into several groups and compared to healthy volunteers, as you see here. The three patient groups were a non-infected group. I have this asterisk here to remind me to tell you that, as you may know, this has been proven difficult to be a group that is able to be filled, because it seems to be that most of the patients that come in non-infected, end up in this burn incipient infection group, wherein they present to the ICU as non-infected, and they develop sepsis at some point in their course of stay. In this study, we defined sepsis clinically as prescription of broad-spectrum antibiotics and one of the following: initiation of pressors, hypertension requiring bolus fluids, or blood cultures drawn. Sampling was done once daily on standard work days for 2 weeks, or once total for healthy volunteers. Let me show you what we did with the actual blood samples. We submitted it to this FICO gradient, where we take the lymphocyte layer, the buffy coat here, and we load that in a fresh manner in these oxygraph machines. They're high-resolution respirometers, and I'll show you what that readout looks like here shortly. We can also store the plasma for future use, where we look at proteins and DNA that are isolated from that plasma. A subset of these patients were looked at in a multiplex fashion to look at certain protein biomarkers, and we did a PCR assay to look at the levels of both 16S DNA, which is bacterial DNA, and DNA targeted by NADH dehydrogenase 3, which is specific to mitochondrial DNA. Stats were run appropriate to whether or not data was normally distributed. Here's what this oxygraph readout looks like. So on the y-axis, you have oxygen flux within the machine. The cells are loaded here, and they come to a routine oxidative phosphorylation as, again, a surrogate for mitochondrial function. We'll add oligomycin, which is an inhibitor of ATP synthase, to look at the respiration in these PBMC mitochondria that are not coupled to ATP synthesis. And then we'll add ionophore FCCP to poke holes in the membrane, essentially, and lead to a maximal, supraphysiologic maximal oxygen flux here. So 17 subjects have been enrolled to date. Again, most of them have been in this incipient group. And although there's slight variation in both age and TBSA, there were no significant differences thus far, and the patients were majority male. Here's the results from our oxidative phosphorylation. The routine respiration, as you can see, where the PBMCs are just happy in their oxidative media, compared to healthy controls, didn't matter whether the samples were from non-septic or septic patients, there was no difference here, virtually identical. If we look at the leak respiration, there was a significant difference from healthy and septic patients, and although the absolute difference here is not that great, largely owing to this variance, there was no significance between healthy and non-septic patients. The biggest difference we saw was in this maximal oxygen flux after the addition of SECP, wherein there's definitely an increase after burn, but it seems to be that this increase in maximal oxygen flux, or as I like to look at it, the abilities of the PBMCs to compensate, is impaired during septic conditions where that's gone down. And this is looping in all incipient patients before and after their onset of sepsis together. Really what we need to do is go back and look at the data to get a temporal resolution. On the bottom, you see this MOF plotted across time, which reveals a couple of things, that there is a significant variation in a handful of these days that are examined, and that we did have some attrition. For example, well, this patient here that had been in the ICU for several weeks, you don't see any error bars there because this specific patient actually died at this time point. But there are variations. For example, the day before the onset of sepsis, we have a jump in MOF, which could be interesting from a longitudinal standpoint. So for the mitochondrial DNA, this proved to be one of our most interesting findings. This NADH dehydrogenase 3, or ND3 as I'll call it, is run against a standard curve, so the y-axis here is in copies per microliter. And while there's no difference between healthy individuals and non-septic or before sepsis samples, after the onset of sepsis, there's a drastic increase in the amount of circulating mitochondrial DNA within these patients. And this is, again, something we need to look at temporally across time, but very exciting as a potential biomarker. The protein multiplex, I'll talk about briefly. This is a subset of patients in our cohort. The top has some inflammatory markers. So, for example, complement C5 here. Compared to healthy individuals, there is an increase post-burn that almost reaching statistical significance, exacerbated due to sepsis. The often looked after IL-6 didn't have any difference between before and after septic conditions. And then CCL8, which is interesting from the standpoint that it's a leukocyte chemoattractant, had a similar trend to complement, wherein burn increases the amount of CCL8, and sepsis tends to increase that even further, again, approaching statistical significance, which may be realized once we do the rest of the cohort. On the bottom, hot topic has been endotheliopathy, or glycocalyx shedding within the circulation, and we looked at both syndekin and thrombomodulin as markers of that and didn't see any difference between septic and non-septic groups, although burn definitely increased those two markers. So in conclusion, oxidative phosphorylation of the PBMCs had nuanced differences post-burn and may be a useful tool if we follow that longitudinally. The levels of mitochondrial DNA will greatly increase only when patients develop sepsis, and this warrants further investigation. And there are some markers of inflammation and endotheliopathy that also warrant further investigation. And like I mentioned, future work is needed to both interrogate the variance and temporal response, and maybe initiate a multi-center observational study, which points out one of the limitations as a single-center and observational study. This should be interpreted as such. And with that, I'd like to thank the lab members. I'd like to thank all of my collaborators, funding sources, and you all for your attention and holding it before lunch. I'm the only thing standing in between you and lunch. So let's, with that, take any questions.